Our first presentation is Circles Within Circles, co-creating tribally driven research and practice agendas. This session is an example of how community-based research can support advancement of data sovereignty in tribal and urban indigenous behavioral health programs. Following the presentation, the presenters will take questions from the audience. Our speakers this session come from the Centers for Indigenous Health at Johns Hopkins University, Dr. Donald Warren, Loretta Gray Cloud, and lastly, Brenda Sivarana Krishna. I hope I got that right. So please join me in welcoming our guests. Thank you.
Pilami Ayelo, Mitaku Yepi. Hello, my name is Donald Warren. I'm Oglala Lakota, originally from Kyle, South Dakota, on the Pine Ridge Indian Reservation. And I currently serve as the co-director of the Center for Indigenous Health at Johns Hopkins University. Very happy to have my co-presenter, Brenda Shivaramakrishnan, present with me as well. And she'll be able to introduce herself a little bit further as we get through the presentation. So we'll go ahead and get started with the presentation, but I do also want to acknowledge the fact that this is a very important discussion that we're having. And historically, in my own experience, I used to work for the NIH. I was a staff clinician with NIDDK, so involved in the diabetes study with the Pima Indians and other Southwest tribes. And what I would observe is that without adequate representation among principal investigators and among the decision makers, quite often we weren't even asking the right questions. You know, without that lived experience, we don't really know what the issues are. And I have lots of examples in my own experience where the research community, being very intelligent and well-trained in methodology, without the lived experience, actually doesn't really understand the circumstances in which our people are living. So it's very important to be inclusive of our communities. So our presentation is called Circles Within Circles and recognizing the holistic nature of our work. And I'll briefly describe our study. So next slide, please. So this study was originally funded through the National Institute on Drug Abuse. And through NIDA, they have what's called the Clinical Trials Network. You may have heard of CTN, the Clinical Trials Network. And it's a network of multiple sites that conducts clinical research to address addiction and recovery. And several years ago, when I was still at UND, they had approached me and said, what are the research priorities for the communities in the Northern Plains? And my answer was, well, we need to ask the leaders in the Northern Plains, and it's not going to come from the research community. Someone sitting at the desk or in a lab isn't necessarily going to know what those issues are. So part of data sovereignty is also creating the priorities and the agendas that we're going to be pursuing. What kind of data do we collect, and what's the rationale for that data that we are collecting? So again, when I was originally approached, we actually got approval then to conduct a study to develop community-driven research priorities around addiction and recovery. And some of those outcomes are really tremendous in terms of what are the practical issues that our people are facing. And they're the types of research questions that would not be generated from the addiction scientists. You know, and they're wonderful people, great researchers, and really good areas of focus, but not necessarily knowing what are those front edge issues that we are facing that we need to study further. So again, this was funded through NIDA, National Institute on Drug Abuse, and we're presenting not just the study, but actually the dissemination process, because that's another important piece of the puzzle when we're looking at data sovereignty. So next slide, please. So this, again, was funded through NIDA, specifically the Ohio Valley node. There's multiple nodes of the Clinical Trials Network, and we had a subcontract with them to work with our communities. And we were very fortunate to have a very diverse research team. So we had Indigenous peoples, but also people representing other communities, European heritage, South Asian heritage, Alaska Native, Two-Spirit faculty, and we had research assistants from several universities as well, from Hopkins, UND, and from the University of Cincinnati, where the Ohio Valley node is located. So we felt really good about our research team and the diversity of thought that went into developing this particular project. Next slide, please. So when we think about the challenges that we face with developing research priorities, we have to have trusted entities, right? We need more of our own people serving in the principal investigator roles. And when I was doing this work 20 to 30 years ago, we had very, very few of us that were in those roles. And I'm very encouraged to see how many of our people and how many of our allies are moving into the arena of research and Indigenous health and learning the methodology from a meaningful perspective, but also understanding the culture from a more meaningful perspective and how those worlds can be brought together. So this study really was focused on a tribally driven research agenda. And we worked with several tribes, went through all the formal approval processes and all of the reporting processes. But again, here we'll talk primarily about the dissemination process. So next slide, please. So we use a tribally driven research a participatory process, and we engaged the Great Plains Behavioral Health Directors Association. Those are the people working at the front lines. And just as a quick note about the wonderful people working in this space, it's a challenging arena trying to work in addiction and recovery. And as we know, the recidivism rates are incredibly high, and we don't have adequate resources, and we're working with limitations in funding, but also human resources. We have terrible staffing shortages. So just to acknowledge the people working in the front lines of this arena really are just tremendous human beings. And they're saints as far as I'm concerned, because they're working incredibly hard in very difficult circumstances, but they want to take the next steps. And I think one of the advantages that we had in this particular process is that we had community members that were part of the research project and developing the priorities. So we really wanted to hear from them. What are the issues we should be studying? Where do we need to put additional resources? And what are the next steps from their perspective? So next slide, please. So in this presentation, we'll provide information really on the dissemination process. And what's really wonderful is you'll get to hear from several of our behavioral health directors and tribal stakeholders. So we have them recorded, and of course we have their permission to share their words and their stories with us. But I think hearing directly from the people working in the space is so valuable, even more so than the research community themselves. So that will be the focus of this particular presentation. And we'll have time at the end for any Q&A as well. So next slide, please. All right, so it's also a reflection of the tribal behavioral health stakeholders and their priorities, and again, the challenges that they are facing. But what we really found that was fascinating is that the solutions that they identify are inclusive of cultural factors and making sure that we're incorporating local culture into the recovery programs and into the paradigms. So we'll go to the next slide and start the dissemination process, and I'll let Brenda introduce herself as well.
Hi, I'm Brenda. Can you hear me? Yes. Okay. I'm also with Johns Hopkins and a research associate there, and also with UND. And just wanted to first start with this. If you notice, we are not using a PowerPoint, and I'm off script right now, but just wanted to share that this is a digital story. And we presented it that way so that we could present it as we would do to the community, in the sense of as a story rather than an academic presentation. So firstly, data dissemination. Often in research, we see this as closing the loop on research, right? But it's also opening a circle of the vast opportunities for communities to change their outcomes, improve their outcomes on their own terms. Next, please. So the actions, this data dissemination process was really powerful because we were able to go in person to most of the sites that were involved with the study. And so actions came out of this, really practical ways to continue the work, as well as some ideas. Next, please. And so one of the actions that came out of this was just as we went along to the sites and an impromptu session with a detox facility, and we walked in just to see the place, and one of the nurses said, "Hey, we'd like to see the data and the presentation." So we just sat down right there and did a presentation for them, and just the grassroots way of how this happened, or just sitting down and having these conversations, casual conversations of what next, was really powerful. And we even had a form that we created just to record the responses to the data dissemination. Next, please. So another action that came out of this was how we could keep supporting this work, because one of the staff members that we met actually said, "I'd love to learn how to write a grant or even find a grant." So my colleague Loretta and I got on a call with him and realized that it was a bigger need to provide assistance to tribal behavioral health professionals who want to increase their skill sets. Next, please. And so we had some actions that came out of this, but also some great ideas. And then these are not our ideas. These ideas were coming from the community themselves, from the behavioral health directors themselves. One of them was documenting the healing power of ceremony, and, as Dr. Warren said, access to culture. And that was one of the biggest findings in this study, was how recovery should include that, access to that. So closing that circle on creating more evidence that shows this for research to continue, and for policymakers and everyone to be able to advocate for this. Next, please. And another idea that came out of this was, in the data, we saw that sometimes people in recovery didn't have a supportive environment to go home to, or something like that. So having community health workers as home visitors for recovery and detox was a possibility of having that person create that healing environment for people to sustain the recovery. Next, please. And another one was also on the same topic, supportive housing, and how a lot of the data showed that having a safe place to go and recover, and having a place to go if they didn't have one, was really important. So an idea that came out of it was researching ways to provide supportive housing on and off reservation trust lands. Next, please. Next, please. And so overall, the goal, as you can see, was upholding that data sovereignty that we're all here to discuss this next couple of days, is support the community in meeting these goals that are sourced from the community and that are supported by the leaders. And so that's a huge outcome that we saw, as both for the study and for the continuation of the work. Next, please. And so now we'll share with you the behavioral health directors who are some of them part of the study, as in their own words about data sovereignty. Next, please. And before we do that, we'll just share in conversation, because these were casual conversations. This is not part of the study. It was our dissemination follow-up. We used this data sovereignty definition, and I'll just read it to you. Actually, I can't see it very well. But But it's basically about keeping the data in the hands of Indigenous people uh, and having them steer the keeping of the data, the usage, the application, and really driving how we work with the data. Next, please. So now we will play for you some of the conversations we had about how data sovereignty impacts these tribal behavioral health directors.
Okay, data sovereignty. How do we define data sovereignty in our program? Work with our own so that we can collect the data that we see is necessary to help our own identify who they are. And we've been on that side of the track, so to say, so we know that lifestyle and know what is needed, what services are needed to address the issues in our culture. So keeping this data is going to really help in our funding opportunities, and in just displaying that we have a way too as a Lakota culture, and to really put it out there into the world that this is how we service our own, and this is what is needed to help our own understand that we have a spiritual way of healing so we can address issues, but we got to heal first. So keeping this data is going to show the world that this is how we do it.
In my opinion, the importance of data sovereignty is pretty much encompasses what the outcome and the end result of what we do for our communities. For example, the best outcomes that I have witnessed and been a part of in terms of developing the tools and actually doing the research and then planning the interventions. I think that the key to success truly in that process is having those of us, the providers in the community, the ones that know the family, the ones that can get the information, because I think it is truly, the data is more reliable when you are a part of the community and doing something you've identified the needs of the community. So being able to own that and process it and use it in the best way for our community reflects, again, the importance of us controlling that data and having that data within and held and used within our tribal communities. With the suicide prevention, it was important that, again, this was identified as a priority in the community, so that that was our knowing that this was at the top of the list. Therefore, that was the project we identified and gathered the data from the families. So much more, I think, when you are familiar with the families and the community, you're going to get reliable data because of the trust factor, because that the people are ensured that this is tribal data and it will be used to establish programs and healing in the community, and using culture as a tool. Again, proves the highest, most positive outcomes of whatever it is that we are doing in terms of health.
Drug and alcohol treatment program, so data to us is really important. And when we bring on new people or our counselors, they always struggle with data because they say, I didn't sign up for paperwork. But if you look at it as our files are the spirit of our people. So when we're passing that information on, we want them to see the spirit of that person so they get an idea how to help that person. So with that thought, we have our team meetings. We work with each other to can, because it's important. And research is part of what we do, and we're so glad to be part of a research project that it helps us tremendously because we know how important that is to get it out to the rest of the country. It's just something that needs to be done. And we got new staff coming in. We're going to train them in a good way. But like I said, to me, the important thing of that is everything we do is the spirit of that person. And we need to keep that going so we can pass it on to the next person who picks up that file or looks at how that person's doing. So.
So the wounds that, we've experienced our own selves. They call us wounded healers. We have to keep working at the issues and develop, the data that supports that so we can continue to help those that are wounded, are totally unaware of, their wounds that they have. So the data that's collected can be used to help our people, to continue to thrive.
Let's show some appreciation for our behavioral health directors and their wonderful perspectives. There's just so much powerful and rich information when we listen to our elders and listen to our program directors and to our community members. And so many of the important things that were described are the importance of culture, that we have our way of healing. And that way of healing has not always been respected, has it? And I think about my own experience in research and really going past over the last 25 to 30 years and how things have really improved in the right direction. 25 years ago, we didn't have the terminology around data sovereignty and we didn't have our own principal investigators. And I also love the discussion around these files are the spirits of our people, right? That it's not just numbers. These are community members. And I remember when I was working at NIDDK, so doing diabetes research, and again, this is 25 years ago, one of the other tribes in the Southwest was seeing very high rates of kidney failure due to diabetes. And my first thought was thinking about the moms and the dads and the aunties and uncles and all the families that were being affected and how devastating that is to actually have a diagnosis of kidney failure. And my colleague, actually my supervisor at doing intramural research, his first comment was, I would love to mine that data. And I understand that from a scientific and an academic perspective, but he removed the humanity out of the data sets, right? And that's not what we do. So when we're looking at data sovereignty and actually making sure that we control the data and set the priorities, I think one of the advantages that we have in this space is that we recognize that the numbers are not just numbers, that reflects people and real human suffering. And I know that quite often when we think about how we fund research in the modern times, we tend to have our silos, right? And isn't it remarkable that we have separate agencies? I mean, is it possible to have someone who has diabetes and addiction and alcohol problems and other things, could it happen in one person, right? But we have to have NIDDK, NIAAA, NIDA, NIMH, and NIMH to study these things, right? It's all separated out. But we don't see the world that way. And I would think that modern science has a lot to learn from us because we see the world as it is in its holistic nature, not just within each individual silo. So the idea of circles within circles and the idea of the medicine wheel and recognizing that we have to respond to these challenges from a spiritual, mental, physical, and emotional perspective. And one of the outcomes that is just tremendous is that the traditional healers, we've had medicine men and medicine women approach us because they want to study their interventions. So one of our collaborators has what they've coined ceremony-assisted treatments. You may have heard of medication-assisted treatment, right? Buprenorphine for opioid addiction. They're doing ceremony-assisted treatment, and we actually got funded to study it based on their priorities. So it wasn't coming from the addiction science community and approaching the community to study it. They approached us because we can establish trust. And that's such a huge part of having effective next steps. I also want to acknowledge our colleague, Loretta Greycloud, who's Kulwi Chasha Lakota from Lower Brule and Hunkpati Dakota from Crow Creek, and her connection to culture and specifically to horse culture and equine therapy in her family. And that's another area of priority that was identified. We have so many cultural strengths, and we're seeing on small scales the value of things like equine therapy for people. And we just got a grant last week to study this further in one of our tribal communities that Loretta is from. So I want to say thank you to Loretta for all that extra connectivity. So those are just a few examples of the outcomes when we ask the community, what are their priorities? And do it in a respectful way. So we're respecting the tribal control of data in terms of the IRB processes, but also doing it in a culturally relevant manner. And we start every one of our meetings with the Lakota prayer. And that's not something that you can put simply into a research protocol, right? You can't just have the non-Indigenous researcher recite the Lakota prayer. You have to feel it. You have to know what the language means. But that can't be done without our own people in this space. So a big part of our next step is growing the next generation of researchers and people who are collecting, analyzing, and disseminating the data, but doing it in a more effective and meaningful way. So next slide, please. I love this image at the powwow and seeing all the young ones and thinking about the real need for connecting across generations. And we're in a very difficult time frame right now, this point in time. But when I look at the numbers of our people going into higher education, the numbers of our people committed to doing this type of work, I feel hopeful about the future. And that's got to be part of our solution too, is that not just quantifying the disparities, but identifying the community-driven solutions. And then that needs to set the agenda for further data collection and further research. So next slide, please. All right, and just want to acknowledge the research agendas that were set by the community are setting our priorities and our agendas. So we're pursuing a lot of research projects and resources to fund the priorities that were actually delivered to us by the community. And I think that's something that can be done across the board. It doesn't have to be just in the space of addiction and recovery. I think for any community, they have their own priorities, and each of our communities has so many strengths around culture and language and land-based healing and all of those really meaningful cultural connections that needs to be a part of the solution. But again, also thank the Great Plains Behavioral Health Directors. They do tremendous work in the face of significant challenges, and that's where we need to continue that collaboration. So next slide, please. All right, so full circle healing and recognizing that when we're looking at the healing and recovery process, we also need safe communities, safe housing. And that's one of our big challenges in the Northern Plains, and I'm sure in many of your areas too, is that a client can go through an inpatient treatment center and have intensive outpatient, and then they go home to the social circumstances that put them into these challenges in the first place. So we can't just think of it in terms of what's the biochemical pathway of addiction and how do we address that. We need all of those social supports. So if we're actually going to be effective and promote healing and wellness, we have to take a full circle healing approach. And that's what our ancestors always did, right? It might not be what we do in modern medicine and modern science, but I think modern medicine and modern science has a lot to learn from our ancestors and our cultures and our ways. So people experience the world in a holistic manner. The solution should be also in a holistic manner. So next slide, please. All right, we wanted to leave time at the end to see if there's any questions or comments. So we'll pause there and first say thank you all very much for the attention. Yeah, any questions or comments? Not all at once. Oh, yes, please.
So I just wanted to say thank you so much. This is exactly after sitting through years of this. I'm from Alaska, and South Central Foundation, we do have our own research department and have homegrown our own, but this really is part of the solution. The culture and even reporting back, I'm just amazed at that. I love it. Thank you so much.
Yeah, thank you so much for the comment. And yeah, I've worked with some of your communities in the past, and what's happening in Alaska is just tremendous. The research infrastructure and the community-driven nature really is a model for much of Indian country. So appreciate all the work coming out of Alaska. Yeah. Yes.
I'm actually doing a senior thesis project on basically the how to find any significance in decreasing diabetes in my hometown. I'm from the Wind River Reservation in Wyoming. And my biggest question is probably how do you find that many participants to openly like volunteer to share that they have type 2 diabetes or anything, because my biggest issue is having a small sample size. And it's just a reality in our community that I personally know people with type 2 diabetes. So it's trying to find as many participants as possible to be openly to volunteer to be involved with my research project. So I guess my biggest question is how do you get people to volunteer to be part of your study?
Yeah, very good question. And actually, we have a Together Overcoming Diabetes research project also in Rapid City. So our Great Plains Hub is hosting that. And what we're doing there is working with the diabetes program. And unfortunately, as you know, in our regions, we have very high rates of type 2 diabetes. And most of our communities have an SDPI, the Special Diabetes Program for Indians. And we just happen to have a really close working relationship with the diabetes program director and some of the other clinicians. But I think it's because we've had longstanding connectivity to the community. You know, we've had the Great Plains Hub for maybe 5 or 6 months, but I've been a community member for 58 years. You know, so just having that connectivity has a huge impact. But also, Brenda worked as a diabetes epidemiologist in Seattle Indian Health Board for a while. I don't know if you had any thoughts on subject recruitment or ideas. Yeah.
It was a similar idea that if you have a local SDPI office and program, partnering with them, because I'm sure they would love to work with you, and having students be a part of it is really transformative for the program and the student. It's a two-way street. So I would suggest something like that, or the clinic or that kind of thing.
Yeah, and I know you also do have a tribal college up there. That might be another avenue to consider. But we also, when we get grants, we do incorporate compensation to people for their time. So there are different formulas to look at. So we want to be respectful of their time and expertise that they're sharing with us. So we do that too.
Thank you.
Hi, I'm Colin Gerber. I lead the tribal epidemiology work at CSTE, and I'm a former colleague of Brenda's, so great to be reconnected. But one thing I'm curious about is, in the world of research, so often we hear the adage, publish or perish, and the importance of kind of building the evidence base. I'm curious if you'd speak a little bit to it's one thing to do the research, and then you have kind of this final barrier of actually getting it published. And how do you overcome kind of the biases of, reviewer number 2 or whatever, who is looking and wondering, why are you doing it this way? Which, certainly was something I encountered in my prior work, working with Urban Indian Health Institute and trying to get things through, papers through CDC clearance and so on and so forth. But yeah, how do you make it over that last hurdle so that this important work actually gets out into published literature to kind of build that momentum.
Yeah, I really appreciate the comment. And for some reason, it's always reviewer number 2, isn't it? I don't know if your experience, but that just for some reason that seems to happen. But yes, we do face those challenges because not all scientific reviewers are going to understand this methodology or the priorities that are community driven that might not be rooted in simply biomedical science or pathophysiology, but are rooted in more community-based factors. So that is a challenge, but it's also an argument for the fact that we need more of our own people going into these arenas, that we should have our own people doing the reviews. We should have our own people doing the scientific review at NIH, but also the scientific review for the publication. So with this particular project, the good news is we have all the approvals in place and we're submitting for our initial 2 publications coming out of this project. But the other thing that I think that is really wonderful, and Brenda is leading this, is looking at co-authorship. I don't know if you want to mention the CBPR paper. Yeah.
Yeah, that's a great question, and I'm not a seasoned published author like Dr. Warren, but we were looking at having all of the behavioral health directors that you heard co-author this paper. And there are journals that would respect that more in the true spirit of community-based participatory research. And just something funny was that we had to get this presentation approved by NIDA, and reviewer number 2 gave a lot of comments.
It's yeah, 1 and 3 said it was wonderful, but they were good comments. But yeah, it's always reviewer number 2. I don't know why. All right. Any other questions or comments? Oh, okay, good. Yeah.
Hi, my name is Desiree Martinez. I'm the tribal epidemiologist. Tribal epidemiologist at the New Mexico Department of Health. And I just wanted to make a comment of like, this is so great. Like the presentation was really well made. It's not like an academic like we usually expect. So it was just nice to see like the storytelling and just another way of presenting the data and presenting, you know, community voices. And I just wanted to say, like, I really love what you said about mind the data removes the humanity aspect, because I feel like a lot of our work with data and everything, everybody's excited about tribal data, but they don't really think about the human aspect, like you said, of it. And I feel like a lot of my work is reminding them, like, you know, you can't use it without permission, and like without the tribe's permission, being like, understand the culture, you know, understand more things instead of just being excited about tribal data because you can try and have access to it. So yeah, I just want to say that was really well said, and I loved the presentations.
Thank you so much for those kind comments. And in our curriculum at UND and in the coursework we're developing at Johns Hopkins, that is an area of focus, is that when we're looking at data sets, that represents human beings. You know, someone's relative is being represented by those numbers. So we don't play with data, right? We respect it and use it in ways that are to be meaningful. And then some of the ways we approach this, you know, with quantitative methods, we're learning what the problems are. Qualitative methods are learning why those problems are occurring. And then mixed methods, it's allowing the people with those diseases that we're studying to share their story and from their perspectives of why it's happening. And then CBPR, the communities get to tell the story. And then with indigenous methodologies, our ancestors get to tell the story too. So it really is storytelling when it comes down to it. It's not framed that way from a typical scientific perspective, but that's exactly what we're doing. And that's why we need more of us leading these efforts. So, but I appreciate the comments.
Oh yeah, it's wireless. Good morning. My name is Eudora, and I'm one of the epidemiologists with the Albuquerque area Southwest Tribal Epidemiology Center, located in Albuquerque. My question is in regards to question and comment. I guess I was wondering if you worked with a local tribal IRB for this research, because I want to get a shout out to tribal IRBs because it kind of helps bridge that gap with sort of a lens from a tribal perspective, and as well as tribal researchers looking into your research. And that's more of my comment, I guess, is just shedding light on tribal IRBs.
Absolutely. Yeah, we did get appropriate tribal approvals. And in our region, not every tribe has an IRB. Sometimes you just get approval through the council or the health committee or the health board. But there are formal IRBs that we did engage. And full disclosure, I'm actually on my own tribal IRB. So I'm the Oglala tribal IRB. So full disclosure that I'm not telling you that. But you know, one of the things that came out of that is when we were proposing the idea and primarily working with the behavioral health programs, one of the tribal IRB members said you should also be engaging other social services programs. And they really recommended that we work with one of the programs that's a children's shelter in the reservation community. And the vast majority of kids that are there because of addiction in the family. And it just sets them up for all kinds of future challenges. So we got input from them too. So not only is it what we should do from a data sovereignty perspective, we'll actually get better research when we engage tribal IRBs in a meaningful way, because they'll have suggestions that we might not have had from the outside. So I totally agree with you, but yes, we did follow all those processes. Yeah.
Hi, good morning. My name is Karen, and I am the chairman of the board at South Central Foundation, and I'm directly involved in the research review process at our organization. I was cracking up at your comment about reviewer number 2, because that would be me. My whole group turned and said, "You're a reviewer too." So I knew I had to make a quick comment. So as part of our tribal review process, we of course go through the scientific review for that kind of accuracy. But then as you know, a tribal, I'm not quite an elder yet, but as part of this tribal review process, the way I think of it in my mind is I think of how would a 90-year-old tribal grandmother feel about this? How you're speaking about her community, the information you're providing, how it's presented, and put that lens on it in addition to the science. And that's usually where, you know, that's what we can bring to the table to make sure that this information is released in a culturally appropriate way and very scientifically strong. So it's the marrying of the two of those that we really look for. So as tribal reviewer number 2, that's some insight to how to tackle that. Thank you.
Yeah, and I think that's just a great comment. Really appreciate that. And when we think of IRBs, of course, the role is human subjects protections, but for us, we also have community protections, right? We have a kind of a higher level of purpose as tribal IRBs. And I know probably many of you applied for the TURBI grants. I hope those things get fully funded, because that's a way to bolster more infrastructure for tribal research review, which we absolutely need. And as more of our own young people are going into these spaces, I'm very excited about the idea of having Indigenous governed research at all levels, including the IRB processes. Yeah.
Hi, my name's Elliot Moore. I'm from Rocky Mountain Tribal Leaders Council. I'm an epidemiologist. And I was going to ask, does the typical scientific separation of generating information through research or evaluation, the separation between that and like program coordination, do you feel that tends to keep out Indigenous perspectives? And if so, what are some ways to close that gap?
Absolutely. And I think that quite often there's a separation between the academic and research community and actually the programmatic community, right? The people who are actually doing the work. And that's a mistake. And it's almost like the historical model is that we'll conduct the research, publish the findings in a peer-reviewed publication, and then hope for the best that it gets implemented, right? So actually one of the things we're working on now, and Brenda might have a few comments as well, is the idea of an Indigenous implementation science framework. That for us, implementation of research findings needs to account for things like historical trauma, the experience of boarding schools potentially within a community, exposure to adverse childhood experiences, but then even more importantly, what are the strengths in the community? So if we're going to implement something that's being generated by the literature, you know, we hear about evidence-based practices. My question is always, whose evidence is it? So we need to generate more of our own evidence, but at the same time, we need to ensure that those findings have a strategy for implementation. It can't just be ending at the publication and being in a manuscript. But I don't know if you had thoughts on that.
Indigenous implementation.
Yeah, Indigenous implementation science framework.
Science.
Yeah.
I was actually going to say that. So.
think we have time for another question or comment. Yeah, okay, great.
So I think one of the things you talked about really is finding out what the priorities of the tribe is. And that's one of the things I think at South Central Foundation that our board implemented years ago was bring us a concept proposal. We have this list of priorities that are important to us. And in that, then, you know, before you waste your time doing all this work, let's make sure it's a priority for the tribe and for the people that we're serving. So that's been helpful.
Absolutely. And just over the years, because I've been doing this a long time, but I've seen the evolution of community-based participatory research. And historically what it was, the research questions and the hypotheses are still being generated by the researcher. And then they pitch the idea to a tribal community. And then if they agree to participate, they call it community-based participatory research, but not really isn't community-based, right? That the research questions, the hypotheses and the ideas and the priorities need to come from the community to be truly community-based. And that's why we want to include our participants as co-authors on the CBPR part of it. So, yes. Yeah.
I really appreciate that. And one of the things that I really like to think about is reciprocity with research and what are you giving back to the community when you go in to do that? Really, I think it's more about it being led by the community, and so many times you're sold on something. And I think that's where I'm curious, like what you've seen in terms of that reciprocity kind of process. And also another thing that's really important is language and recognition. I know I was a health director for many, many years, and then joined the board of South Central, but I would always see these kind of self-defeating kind of descriptions of community, and it was really hard. And slowly over time, we've changed a lot of that and really built in some really respectful language. Thanks to reviewer number 2. And I'm just curious, like what changes you've seen and recommendations you have around that.
Yeah, excellent question, excellent points. We typically have heard our stories around deficits and disparities. You know, so we'll talk about the terrible rates of disease or other challenges, but we don't hear enough about the strengths. So, I mean, ironically, we kind of had been trying to move from disparities to equity, and now that's a challenge, right? But I think this is a blip in time because we still are focusing on equitable outcomes for our people. That's just the truth of what we're looking to do. So I agree the language around it is important because we don't want to just create stigma. We want to be able to have meaningful outcomes. And in terms of reciprocity, for this particular project, we've now pursued several grants and been awarded to implement studies that are based on community-driven priorities. And one of our other community just said in a very practical way, they're engaging the high school that has a lot of at-risk kids. And they said, I mean, do you know of anyone who can actually be a math tutor for high school kids? And Brenda stepped up and actually became a math tutor as part of the outcomes for that. So, I mean, just shout out, good job, you know.
Yeah, thank you. I love those comments from all of you that one of the reasons we made this as a story instead of a PowerPoint is because it's very easy to share. Me and Jeannie were talking about that. So I hope everyone can have a link of the story. And one of the things that was really useful was documenting their responses to the dissemination on a little form, just like on the spot made a form that said, okay, how are people receiving the data? What do they want to do with it next? And how can we help them do that? And so it's an accountability for us as researchers to do our best to support that. And then also seeing how we could do it better next time. And also, as you said, and a number of you said, linking the program with the research, and that form could even help you do that in your researches when you give it back, see what they say. Because I found that we hadn't thought of doing that, but it was fascinating to actually go back and read what they had said in the conversations and how we could help them with next step, as Dr. Warren had shared.
Yeah, yeah. I think we're at our time, but just wanted to say thank you all very much for your attention here. Thank you.